doesn't project real well, but these are just the incidences of cancer in the United States. The top one is estimated new cases in 2014. You see prostate, lung cancer, and colorectal cancer for men, breast cancer, lung cancer, and colorectal for women. These are the top 3 cancers diagnosed in the United States in 2014. The estimated deaths from cancer, you can see the lung cancer and prostate cancer kind of reverse themselves for men, lung cancer being the #1 killer in both men and women, breast cancer as well, #2, where it kind of flip-flops as far as what the incidence is. Over. Oh, sorry. Okay. So looking at epidemiology as far as cancer deaths over the years, you can see the chart starts from the 1930s all the way to 2010. And you can see the #1 cancer that has come to be the #1 killer of both men and women is lung cancer. You can see the trend is going downwards with smoking cessation. That is improving. You can see women, the peak never reached as high, and it's starting to come down as well. So if you don't remember anything from my talk today, remember, smoking kills. All right, so I like this picture as Joe Camel with a kind of Sopranos type of look to it. All right, so cancer treatments. Let's talk about the various types of treatments for cancer. We always like to go through this and kind of spell out what the different approaches are. It's real important to kind of approach cancer in a multidisciplinary fashion, meaning that it's not just one physician that should render an opinion about how a patient is treated. It should be the whole team. It says, in your case, Dave, there's a choice: elective surgery, outpatient medicinal therapy, or whatever's in the box our lovely Carol is holding. So that's what most people think of radiation oncologists. No, most people don't understand what we do. Even some of the physicians don't understand what we do. All right, so you have surgery. It says, good news, Mrs. Bryan, I think we got it all. So basically, sometimes too much surgery is not a good thing. All right, chemotherapy, Joe Camel never looked so good. And then this is what most people think of radiation oncologists. These dragons, fire-breathing dragons, burning our patients or dressed in these lead-lined suits, handling radioactive material. And for sure, that's furthest from the truth. All right, so most people think of radiation like this. These are these high-end radiation machines, which one of my surgeons called more of a glorified tanning booth, because he'd send a patient to me, we'd treat them, and they would have this nice tan in the area that we treated them to. I think these are a little bit more sophisticated than that, but these are the high-end treatment radiation machines that we have out there that are not proton machines, but are still very effective in treating patients. These are the Trilogy and Synergy machine that does the standard bulk of what most radiation oncologists will do as far as standard treatments. These are some of the more fancy treatments that utilize kind of a CT scanner approach to it, so tomotherapy and a CT scanner built into the room so they can image the patient before they deliver the treatment to make sure they're in the right location. And these are some of our stereotactic machines, which deliver a high intense dose of radiation to a very small focused spot, and those are for more tumors in the brain and spine. Okay, so with all these different modalities, how do we choose the best one? Well, what we have to do is take the modality. We have three-dimensional conformal radiation, intensity modulated radiation therapy, stereotactic radiation, brachytherapy, where we actually put radiation inside of people, particle therapy, which is proton therapy, and also electron therapy, and then the different techniques with which we deliver that. So IGRT stands for image-guided radiation. So as we've become more and more sophisticated with how we are able to image and show where the tumors are, we're actually able to use that so that our delivery is more accurate and precise. Gating, so when people breathe, things move inside the body, and when we're delivering radiation, it takes minutes at a time, and so tumors might move in and out of the radiation field. Normal tissues may move in and out of the radiation field, and we want to make sure we're hitting the same area the same way each and every time. Adaptive radiation therapy, or adaptive RT, means that as the patient is going through radiation therapy or different types of therapies where they're getting surgery or radiation and chemotherapy all together, sometimes the tumor can change. Number one, the tumor could get bigger if it's not responding to treatment. Number two, the tumor could start getting smaller if it does get response to treatment. And obviously, when the tumor starts to change in size, we want to be able to accommodate for that and not just treat what we did at the very beginning, because obviously that wouldn't treat the right area and may start treating some of the normal areas that you want to avoid. So all that put together, combining the modalities and the techniques, is where we receive optimal radiation therapy. So the goal of radiation has always been to improve the therapeutic ratio. And what that means is we're trying to increase the dose to the tumor, obviously to help kill the cancer, and then decrease the dose to the healthy tissue so that we don't cause any damage that is unnecessary. The goal of radiation has been this for centuries. Protons is really the next evolutionary step to achieve that, and I'll show you why. All right, so let's go back in history. I kind of am a little bit of a history buff as far as how this field came about. So back in the late 1800s is when radiation actually was discovered and to be utilized for any medical reason. So a professor, Röntgen in Germany, discovered X-rays when he had this cathode X-ray tube that he put a little cloth over, and when he actually stuck his hand in there, he could see his bones on the actual screen behind there. So when he was actually the first one to do an actual X-ray, this is one of the first X-rays that were ever done by Mr. Röntgen on his wife. That's the wedding ring there. So this is the first documented X-rays ever done. Not very far afterwards, Thomas Edison in the United States actually created a X-ray tube that was also utilized for similar medical and diagnostic purposes. So those were manufactured radiation. When it came to natural radiation in the world, they found uranium. So this Professor Becquerel was the first one to find uranium salts that emitted radiation that was not much after the X-ray tubes were formed. And then in December of 1998, a very famous person, Pierre and Madame Curie were the ones who announced the discovery of radium. And radium was actually the first radiation or radioactive material that was actually used for medical purposes. And actually a nice little historical perspective from Chicago was the fact that the first radiation oncologist, the first one to actually use radiation for a medical purpose, was actually a medical student that was kind of playing around with one of these cathode ray tubes. And he was a medical student at Hahnemann Medical School. And he discovered this capability and started doing radiation for breast cancer patients who couldn't have surgery, and they actually would do this type of treatment. So he was credited with being the first radiation oncologist. All right. So unfortunately, they didn't know how bad radiation was for you. So they kind of did their experiments with no protection, and these were some of the things that were happening to some of the early pioneers of radiation. Radiation exposure would cause a lot of burns, amputation of limbs, causing cancers to form. So the obituaries of the first radiology pioneers were quite full at that time. All right, so I'm probably violating a lot of copyright laws with this. I don't know if anybody's familiar with the subject for dummies type of approach, but nobody, I'm not saying anybody's like that, but I just use that for illustration purposes. So let's talk about radiation and how we use it to treat cancers. All right, so how does radiation work? So a lot of people think of radiation much like a laser, so that we go in and just destroy the cancer. It actually doesn't happen like that. It actually happens at a much lower level, where when you damage, or how radiation damages a cell, whether it's a cancer cell or normal cell, is actually at the DNA level. So DNA is what is the kind of the blueprint for the cell to do everyday work and job and living. And so what happens is radiation can directly hit the DNA and cause these little areas to break apart. And then when they break apart and the cancer cell tries to grow and divide, it can't do it. The other thing it can do is it can actually hit a water molecule, knock one of the hydrogen off of that water molecule, and then what happens is it becomes what's called a free radical, or a very unstable structure, and that unstable structure will go in and damage the DNA. So bottom line is it's really kind of damaging the blueprint of the cell's survival in order to kill it off, and not just destroying the cells as a laser would do. Okay, so how do we typically do radiation? The most basic form of radiation at this point is what we call three-dimensional teletherapy, or three-dimensional radiation from the external. So what we do is we take a CT scan, we basically outline the CT scan, we outline the shape of the patient, we outline the different various organs inside the patient and also the tumor. And It is a fairly time-consuming project. It takes several hours to basically contour and draw all the areas that you want to target and all the things that you want to block out. So for example, in a patient who has prostate cancer, first thing we'll do is we'll outline where the prostate is. So you can see here, here, here. It's sitting above, or I'm sorry, the prostate is sitting below the bladder and in front of the rectum. And then you start drawing in all the structures. So there's the bladder, and there's the rectum along the back side of it. And then what you then get is a three-dimensional rendering of what the body looks like. So these are the hip bones. This kind of lighter gray material is kind of the external part of the body. You have the bladder that's kind of sitting in front, and then you have the rectum that runs along the back side. And then I can design a radiation beam that goes in and try to just treat this area and minimize damage to the other areas. And so what you have initially, as far as a simple way to do radiation, is let's just treat this with a 4-field approach, where you have beams coming in from the front, behind, and from the sides, where they all crisscross is where the most intense radiation dose is, and all the while you do have a low dose that's kind of going in through where all these paths are. All right? Because of how much exposure to the normal tissue that gets, and it creates kind of a box around the target area, you're treating a lot more things than you need to with that, with fairly high doses. So when they stepped up that treatment to something called conformal radiation, we started using more angles to basically shape the radiation. Instead of looking like a box, it's actually forming to the shape of the actual tumor. And so that also improved things, but you still had a lot of exposure to the other areas. So along comes IMRT, which is intensity modulated radiation therapy. This is the most sophisticated form of radiation out there. And the way it works is that not only are you accounting for the 2 dimensions of the shape that you're aiming at, but you're also accounting for depth a little bit with this treatment. So I'll show you what that kind of looks like. So in a patient who has a prostate cancer sitting in the middle here, as the beam comes in, you can see these leaves are kind of sliding in and out of the radiation field. So there is radiation that went through this whole area, but because of the leaves sliding in and out, it actually kind of slowed down the intensity of the radiation at various levels. So it shaped the radiation around the tumor much better. So you can see the high dose area in this treatment is much more conformed to the target area than what I showed you at the beginning. So that's kind of been the evolution of what you can do with standard radiation. But what you don't see here, and what I'll show you later, is that there is going to be a lot of low dose radiation throughout the other areas that it came in through. Okay, so what about proton therapy? So back in the day, not much after actually when we first discovered X-rays, we had this professor in England who discovered the contents of an atom. So what he did was he took an alpha particle, accelerated at a nitrogen gas, and then what came out was an oxygen molecule and a proton. All right, so from that, he started doing experiments with that. It wasn't really until the 1950s that this doctor in the United States started to think that you could use protons to utilize for treatment purposes. Now, he's actually very famous for something else. So this is Dr. Wilson. He was very famous for being the group leader of the Manhattan Project. And as we all know from the Manhattan Project, that was not so good for people. That was designed to build the atomic bomb. And so he did that during the wartime, but afterwards he is working towards helping mankind in developing the proton facilities at Berkeley and Harvard, and also he was the architect for the Fermi Lab and designed how particle therapy could be utilized in a medical sense. So kind of following the timeline, Dr. Wilson first proposed using protons clinically. Then from there, the first patient was treated at Berkeley in California. And actually, this facility is really no longer working. It's really just treating eye patients now. But at UC Berkeley, what they did was they actually treated women with metastatic breast cancer. And so we know breast cancer is kind of hormone driven. So female hormones kind of help the breast cancer growth. And so what he did with his treatments was he aimed it at the pituitary gland, with protons at the pituitary gland. So he wasn't really even aiming at the breast. What they did was they knocked out the pituitary function, which then the pituitary is the hormone regulator in the body. It actually reduced the female hormone or estrogen in the body and helped breast cancer patients that way. So they started those treatments initially at Berkeley. And then from there, the Harvard Cyclotron was built in Boston, and they kind of continued this work and treated a lot more brain type of tumors. And then in 1990 was actually the first center, because a lot of these centers were kind of physics laboratories, and so they were kind of treating patients kind of as an aside thing. Most of it was doing physics experiments. In 1990 was the first facility, the Loma Linda University Medical Center in California, was the first one that was designed exclusively to treat patients. So that was when it really kind of came to be as far as proton therapy for the masses. So Loma Linda treated their first patient in 1990. They had this machine. Initially, all the machines were just directed one direction, and you'd have to move the patient in order to guide their beam where it needed to go. Loma Linda was the first one to design this 360 rotation type of machine so they could treat from any angle. All right, so now proton therapy is much more available. Much more available as a relative term, because it started out with Loma Linda in 1990. Then University of California, Davis happened in 1994. And then in 2001, Harvard Cyclotron then became a clinical center in 2001. MPRI, Bloomington, Indiana, was really the fourth facility built in the United States. And then in 2006 is when kind of the explosion of different centers started. So you have MD Anderson in Houston, Texas, University of Florida, you got Oklahoma City in 2009. My alma mater as far as my training facility, University of Pennsylvania in Philadelphia, Hampton University, and our facility opened in 2010 in the fall. You have now Princeton after us, University of Washington, WashU in St. Louis, the Scripps Proton Center, and the Provision Proton Center. Those are two that opened just this year. Okay, so if you want to look at the map, when I say the proton centers are exploding, it's still a relative thing because obviously there's not that many proton centers out there, but they're starting to open up. So 2006, you have the initial 6 centers that were available at that time when the first explosion happened. 2009, the Oklahoma City facility opened up, and then 2010, you had our facility, you had University of Pennsylvania and Hampton, and then 2013 is when you had the other 2 in Washington and New Jersey, and then I didn't have on here the 2 new ones in both the Scripps and also the WashU one. All right, so here are some of the future ones. Around here, you have Mayo Clinic, who's opening theirs in 2015. They're also opening one in Scottsdale, Arizona, their satellite facility. You have one in Flint, Michigan, that's having a little bit of trouble getting open. They were slated actually to open in 2013, but they had to push things back. This is actually a machine that has been designed in Russia and has just had a few more glitches in kind of getting up and running. St. Jude's is going to open up one with a Japanese system. And these are some of the other ones that are coming on site fairly soon. Okay, so our facility opened in October of 2010. We treated our first 2 patients. They were both pediatric patients. One was a back of the brain tumor. One was about down in the spine. Actually, of note, one of the first 2 patients was from Glenview, so a very local girl that we treated there. And she's doing wonderfully now. All right, so how does it work? Okay. So here's where we get down to a little bit of the differentiation of what protons is. So regular radiation is called X-rays or photons. And this is the energy curve that the photon follows. So if you have a tumor this depth in the body, in order to get the beam there, you send the beam in, and at the skin surface, there's not much energy given off. About an inch into the body, or about 1.5 centimeters, it kind of builds up to maximum energy, and it slowly dissipates that as it passes through. So that one beam gives only a fraction of its energy to that target area. With protons, when you send it in, it also has very low energy at the skin surface. But because it's a tiny particle, it's moving very quickly. Depending on how quickly we send it in, it goes to a certain depth, slows down, and stops. And then it collides with what it stops at and transfers most of its energy to where it stops, and then nothing goes beyond it. So you can see most of the energy is deposited where we want it to. There's nothing going beyond it, and there's very little at the beginning. So you can see it's a much better distribution of where you want the radiation to go. So let's kind of show the 2 curves on top of each other. So when you have a situation where you have a tumor of this size at this depth in the body, you have healthy tissue in front of the tumor, healthy tissue behind. If you had a amazing beam that didn't do any damage to the healthy tissue in front and behind, this is what it would look like. We don't have anything like that yet. But what we do have is the high energy X-rays, which is the regular radiation. You have to bring in multiple beams, like I showed you before. Because of the inefficiency, you have to use multiple beams crisscrossing at the target area to bring it to full dose. So this is what the energy curve looks like. Okay? Healthy tissue in front, healthy tissue behind gets exposed. With protons, one pulse of the protons treats about 1 to 3 millimeters layer of a target area. So obviously, the tumor and targets are usually bigger than that, so we have to send in a few more from the same direction, and the sum total of all of them is the red line here. Okay, so you do have some healthy tissue in front of the target area that will get exposed to radiation. So it's not zero, but the dose here and here is all the excess you're going to get usually with the standard radiation that you're not going to get with protons. All right, so how do we form protons? Well, protons is just a positively charged particle, and the simplest form of an atom we have is the hydrogen atom, and that has a proton and electron. And so with hydrogen gas, we can actually heat it up, separate the proton and electron, use a magnet to pull it into what we call our cyclotron, and then use these alternating electromagnetic fields to accelerate that. And as they accelerate faster and faster, when it reaches its maximum speed, it's shot out of the head of the machine. And this is what the cyclotron looks like. So it's about, I would say, 8 feet tall, about 20 feet across. It's a circular structure. It sits on the first floor of our center, probably some distance from where the treatment rooms are. The machine accelerates the beam. It comes out, and then I said it comes out at maximum speed. Obviously, maximum speed would mean the beam would go straight through the body. So we want to slow it down to however deep we want it to go. So there is something in here that basically has various thicknesses to slow down the beam to the exact depth that we want it to go. So that's what happens here. Then it shoots down the line, and all these different magnets send it into the rooms at various directions in order to basically tune it and direct it to where we need it to go. This is what the room looks like when the patients are in there. So not much different than other standard radiation rooms. It's a little bit bigger. The tables are fairly the same. The one thing we do have is robotic tables, so that when you're on there, we have complete directional control of where your body can be, so we can bring the beam in from any different direction. We also have an innovation that we have at our facility that was instrumental in our facility being one of the leaders in pediatric cancer treatments, is that we have this kind of reduced, compressed, condensed anesthesia unit for these pediatric patients. So everything's built in on one platform, so it can move along with the patient. It makes it much more efficient to get the patients in the right position and have them safely treated under anesthesia. We also have a treatment chair where a lot of people who are getting radiation treatments are laying on their backs, and sometimes that's a problem. If you have a lot of problems with lung cancer and difficulty breathing, it's very hard sometimes to lay flat. And so we have a treatment chair to be able to deliver some of those treatments. All right. So this is the kind of the aspect of the treatment and how we are able to customize it for each patient. So the head of the machine has this snout on it, and in the snout we have these various devices to shape the radiation. So as the proton beam comes out, it comes out pretty much like a rectangle, depending on what the kind of closure is at the head of the machine. And then what we do is we put these customizers in, and they're customized for each patient. So we have this brass aperture, which basically shapes the beam to the 2 dimensions that it needs to go. And then we either have a wax or a lucite compensator. And what this is various depths are kind of cut into it, so that the thinner this material is where the beam is going through, the deeper the beam is going to go. The thicker it is, the more shallow it's going to go. So just showing you what that looks like. So as the beam comes through, it goes through the 2-dimensional shaping mechanism, and then you have this lucite device where it's really thin here, thicker here, and you can see, let's say this is the tumor, this is the structure you don't want to hit. So where it's thinner, it's going to penetrate deeper to kind of hit this area of the tumor. Where it's thicker, it's going to be more shallow. So we can kind of customize it based on the shape of the tumor and the shape of the person's body. All right. So why would we choose protons? All right. So it says you've got 6 months, but with aggressive treatment, we can help make that seem much longer. All right. So we never want to make the treatment worse than the disease. So we always want to be able to treat the patient and maintain as best quality of life as possible. So these are the clinical indications. I'm not going to read the whole list, but essentially we treat everything from pediatric cancers to thoracic cancers, breast cancers, eye cancers, things in the spine and back and head and neck, and also in the gastrointestinal tract as well. All right, so let's do a little bit of comparison, kind of apples to oranges as far as the various treatments that we can deliver with regular radiation and what we can do with protons. All right, so first off, pediatric cancers. This is something where we clearly have a distinct advantage over regular radiation, and the advantage is really important because most of our pediatric patients have a lifetime to manifest the damage that they could be exposed to. So that's why it's critically important. So looking at this study, they looked at the patients who had something called medulloblastoma. And medulloblastoma is a very common pediatric cancer that sits in the back part of their brain. And in the past, the cure rates were roughly about 20 or 30% when they just would have surgery by itself. Then, when we did surgery and radiation, the cure rates went up to about 60%, so that was good. Finally, what we've been able to do is adding chemotherapy on top of the surgery and radiation have gotten the cure rates up to about 80 to 85%. So that's a tremendous gain in a treatment that had a less than 50-50 shot in the beginning of being cured. So with the treatments that we've been given, with the patients who are surviving, we started to notice they had a lot of neurologic issues afterwards. And so also a lot of issues with intestinal, thoracic, and abdominal type of problems. So the reason why is when we treated these patients, because their tumor sits in the back part of the brain, it had access to kind of drop seeds of cancers down into the spine. And so when we treated these patients, we had to treat their brain and spine initially. And so when we did that, with regular radiation, we can treat the brain from the sides and kind of prevent any dose from going forward. But when we had to treat the spine, we had to treat it from the back. And when we treat it from the back, you can see everything in front gets exposed to radiation. And so these kids who we treated had a lot of problems with their heart, their lungs, their intestines, bladder, all those areas that were exposed unnecessarily because the tumor would never have gone to those areas, but unfortunately in order to cover what was in the spine, we had to treat that. Okay, so with the protons, we were able to stop the beam before it went there. And this is just an example of how we know that that actually happened. So with this, which shows that this is the MRI scan of a patient's spine before treatment. This is how we planned his treatment, where the beam would stop right there at the halfway point in the spine. And then this is the MRI scan afterwards, and the MRI scan actually shows where the radiation stopped because there are changes in the bone when radiation goes in there. And you can see right where the edge of where the radiation went, none of the anterior structures of this patient ever got radiation. So that's why a lot of these patients are coming through this now without any sort of long-term intestinal, thoracic, heart, lung issues. All right, and this is just the last slide on this aspect where we're treating the back part of the brain in these patients. So we treat the brain and spine, and then we treat the back part of the brain. So IMRT, like I said, is the most fancy form of regular radiation we have out there. We're treating the back part of the brain. With IMRT, you have to come in with many various beams, and you can see all the parts in front that you're damaging. With protons, we can kind of confine it to there. If you actually did a subtraction graphic where you subtract the IMRT energy with the proton energy, you can see here it's clear because both are equal, but the red, yellow, green, that's all the excess radiation you're getting with the IMRT that you're not getting with protons. All right, so prostate cancer. Now, prostate cancer has the two main structures that you're worried about, which is the bladder and the rectum. And so with the prostate, in order to get this to full dose, with IMRT, you need about 5 to 6 beams in order to achieve the maximum dose to that region. With protons, you only need 2. And so with that, you can see that if you do the subtraction graphic like we talked about before, you see the prostate dose is the same, whether it's IMRT or protons. You see it's clear here, so the entrance doses from the sides are the same. But the red, yellow, green, blue, that's all the excess radiation that the IMRT gives you that the protons don't. All right, for lung cancer. So lung cancer is one where we have a tough time with as far as cure rates. You can see here with even the localized disease, so stage 1 and 2 disease, the cure rate is only about 50-50. With the more advanced, what most people present with, because these tumors are very rapid in growing, stage 3, it is about a 24% survival. So only a quarter of our patients survive. So it really is the very difficult cancer to control, and we're just not doing a good enough job with it. Now, what we've learned is that because of where these cancers are located, it's very difficult to get the good radiation dose that we need to kill off the cancer. And so this is the demonstration of a stage 3 lung cancer that kind of involves the right part of the middle part of the chest area. In order to get those there, the IMRT has to send in multiple beams like this. The protons is about 3 beams like this. This doesn't look dramatically different. But if you actually did the subtraction graphic like we talked about, you can see here it's clear where the tumor is, but this is all the radiation dose that's kind of spread throughout the lung. All right. So for skeletal tumors or spine tumors, this is obviously excellent, just like when we looked at that medulloblastoma case. If we're treating a tumor right on the spine area with IMRT, all the exit radiation is going to end up with that excess throughout the rest of the body. This is actually a great example. I had this 22-year-old girl who came to me. She was in the last year of college. She was a superstar soccer player, and she just noticed that last season that she was just having a hard time kind of keeping up and running, and she had a lot of pain in her back. She thought she pulled a muscle. So she did a lot of chiropractic type of approaches. She did a lot of other things, physical therapy, rehab. It just didn't get better. Finally, they did a scan, and they showed this area, this dark area, which really should all look white and bright like that. And it actually turned out to be a very aggressive, but still a benign tumor. So her survival would be pretty good with this. If they could, with benign tumors, most of the time surgical removal will take care of things, but you can't surgically remove the tailbone area, because the tailbone, you can see if you remove this part, basically her whole pelvis would cave in. So there was no surgical option for her. So she came to us for treatment because of the fact that when she went to a regular radiation doctor, she said they told her, we're going to burn your bowels, we're going to burn your bladder, and you will become infertile, because all that stuff is contained in the pelvic area. So we actually saw her and ran a plan where we actually did a plan with regular radiation, which is down here, and you can see all that radiation dose going towards the bladder, towards her uterus and ovary areas. And then we did a plan with the proton therapy. And you can see how we contained all the treatment to the kind of tailbone area and really preserved everything in front so that the dose that was going to her intestines were minimal. Dose going to the bladder was almost 0, and the dose going to her ovaries was 0. So I can't say there's a 100% chance that she'll have fertility, but this gives her the best chance and still gets rid of the tumor. And so she is now 2 years out. And with this experience, she actually is looking to become a radiation therapy technician because of her experience. So I think it kind of speaks volume to what we can do. All right, so this is another example. And this is a case that we didn't treat, but one of our sister facilities in Oklahoma City treated. And it really illustrates very, very well what happens when you treat with 2 different types of modalities. So you can see here, these are actually 2 different patients. This patient is 13 years old. He came to Oklahoma City facility in 2006 in March. This is a kid who came in June of 2006. The only difference was that in the span of March to June in 2006, they opened the Proton facility. So this patient got regular radiation. This patient got protons. So just looking at the plans of their treatment, this is the 13-year-old who came early, got IMRT. So you can see here, it's kind of hard to see, but if you want to look at this green line, it's going here. That is the 10% isodose line. So 10% of the dose of the radiation was basically covering his entire abdominal cavity. Whereas over here, the green line is basically hugging where the tumor is. This is the 50% isodose line, which basically covers about half of his entire abdomen. And then the 50% line is basically hugging the tumor area. And the target area is fully covered with the treatment. Okay. This is a year and a half after the treatment. So just look at this kidney and this kidney. So this is the kid who got proton therapy. This is the kid who got IMRT. So unfortunately, because of this, they both were cured, which is great. But this is the kid's kidney function that had the regular radiation. So usually you want your creatinine below 1. So over the span of about a year and a half, his kidneys are failing, and he's being seen by nephrology. He has not yet undergone any sort of dialysis, but that is the kind of direction that this child is going in. So this is the quality of life issue that we run into with our kids that we can cure. All right, lymphoma. Lymphoma is a lymph node type of cancer in the middle part of the chest usually. It can happen anywhere where lymph nodes are, but the predominant occurrence is the middle part of the chest. And so that is something that we've looked at multiple institutions at what can we do to help reduce the damage that we cause with our treatments, because we can damage the lung, the esophagus or the swallowing tube, or the heart. And so MD Anderson looked at their data, and they were able to reduce the lung dose by about 1/3, more than half of the esophagus dose, and about half the heart dose. At University of Indiana, they were actually looking at breast dose, because actually a lot of the young women who develop lymphoma and then get the radiation, they actually have a higher rate of breast cancer long term. And so reducing breast dose is pretty important for our lymphoma patients that are young women. And so what they found is that they can reduce the mean breast dose, or the average breast dose, by 80%, and then the maximum breast dose by about 10%. MGH or Harvard, they were able to do very similar studies looking at lung dose and heart dose, also reducing them by half or more. And then we looked at our treatment and recently demonstrated this in our abstract, and we'll be publishing this data, looking at reduction in lung dose by more than 3/4, over 60% the lower lung dose, which can lead to what we call pneumonitis. Esophagus dose by 1/3, heart dose varied depending on what you're looking at, from half to 3/4. And this is what we're going to show you as far as an example of how we can do this. So this is what we standardly would do for lymphoma that's sitting kind of in front of the heart, this anterior mediastinum. And in order to treat this with regular radiation, we'd send in beams that crisscross here, and then a beam that would come in like this. And you can see all the areas that are getting radiation dose with that. If you step into intensity modulated radiation, you kind of try to sweep the dose a little bit like this, so it's not penetrating as deep, but then you're spreading radiation dose across the chest. And then finally, this is what protons look like. So obviously, still some normal tissue dose, but definitely a lot less to the other collateral areas. All right, breast cancer. This is something that we're very excited about, because breast cancer, we have a very good cure rate with radiation. But what we just found out, our New England Journal actually just published something about, I would say, a year ago, where they looked at patients who had left-sided breast cancer, and their rate of cardiac events were 3- to 4-fold higher than women who had right-sided breast cancer or no breast cancer at all. So what's happening is the coronary arteries and the heart muscle are in the radiation fields that we do for breast cancer. And so because of that, it doesn't happen right away, but somewhere down the road, that damage will manifest itself into narrowing and scarring of this tissue, so that patients have reduced heart function. So if you look at a comparison in women who have locally advanced breast cancer, we have to treat their chest and also the lymph nodes of their lower neck and in the armpit area. This is the type of treatment we'd set up. So protons would treat it like this. Regular radiation would have to go through and through. And this is just a comparison of this is the excess that you're going to get with regular radiation. Down a little further, where you're close to the heart, this is what protons can do. This is what regular radiation could do. And again, this is the excess that's going to be there. Down a little further, where we're starting to run into the stomach, you're going to run into the liver and the spleen. This is the excess that you're going to get to all those areas with regular radiation. All right. So retreatment of recurrent tumors. So we've heard a lot in patients who will go to their doctors after they've had cancer treatments with radiation, chemo, surgery, and then if something comes back, they're told, well, we have nothing else to offer. And a lot of people will ask why. Well, It's because the body doesn't really forget all the treatment that it got before. So it's already at a disadvantage if we're thinking about adding more treatments. But the reason why we would consider reirradiation with protons is the fact that protons don't venture into areas overlapping on the previous as much. So just why do physicians don't offer this? It is usually a lot of critical organs around there. There are a lot of critical tissues that can only handle so much high dose radiation. And are the tumors more resistant to radiation? So we can't just give a mild dose of radiation to get there. We really have to give dose that we would think that could kill off the cancer even with the first go around. All right. So most people, most radiation doctors will say no to this because it is pretty serious. When you treat with radiation again, there's a lot of side effects that can come into play. So 50% will have serious side effects in patients who are retreated with radiation. There are sarcomas. Head and neck cancer retreatment. Dan Haraf is at the University of Chicago. He actually quoted a mortality rate from the treatment of a little over 10%. So proton therapy is well suited to this, like I showed you, because of the fact that we don't have as much collateral radiation. And so with this, we're actually participating in a study out of the University of Pennsylvania, where patients who are being retreated with radiation are enrolled on this study so we can track and see how well we do with it. We're trying to come up with parameters that we know how much radiation is allowable in the combined fashion so that we can do it safely for our patients. All right. So I showed you a lot of pretty pictures and graphs. Well, does it mean anything? Because a lot of people have said that, just because you have all these pictures showing how good the radiation distribution is going to be, do you have any data? And that's what I'm going to show you now. But I want to give you a quote that I think just makes a lot of sense, is that radiation complications really can't occur in tissues that haven't seen radiation, essentially, right? So if I design a radiation treatment that hits the target and doesn't cause any other damage, do you really need a study to show you that that's going to have a better outcome than the standard radiation that we use? Also, everybody else is kind of doing the same thing. So if you talk to surgeons, what is their latest innovation is robotic surgery, right? Why are they using robotic surgery? Not because they like gadgets, maybe that is part of it, but in the kind of video game age. But bottom line is they are doing this because those procedures are less invasive. They don't have to make this big gaping wound when they do the procedure. They handle everything with these robotic arms and this microscope that can see in fine detail. So they don't have to have their head in there. They don't have to use their hands. And so this is something that they're trying to do as well, limit the collateral damage. Chemotherapy doctors are using now targeted therapies. So these therapies that are antibody type of therapies, I don't know if anybody's kind of heard about some of the therapies out there where it's not really chemotherapy. They're giving injections of different proteins that will actually go and bind to the tumors because they've been designed to kind of look for tumors and attach themselves to it. And then it stimulates the immune response so that your own body goes off and tries to kill them. And so that is being coupled with regular chemotherapy and radiation and seems to have some benefit, and it's supposed to limit the collateral damage. Chemoembolization, this is some treatments where they actually will inject chemotherapy down an artery and then block it off so that the chemotherapy stays in circulation right around the tumor. So everything is about limiting collateral damage and maximizing the damage to the cancer. All right, so with pediatric malignancies, some of the data is shown here. So this is data from medulloblastoma. This is from Harvard, actually. And they looked at the patients who received protons versus regular radiation. The chance of causing damage to the lung was 0 versus 60%. Reduced exercise capacity, EKG abnormalities, so kind of heart and lung type of functions, was anywhere from 31 to 75%. Growth abnormalities, which is kind of hormone function problems because of the pituitary gland, that was only 20% with protons, and almost every patient had it with photons. Finally, the most important thing that a lot of parents actually and the kids want to know about is it going to affect their mental capacity? And so looking at IQ point drops of 10 years, of 10 points at 6 years, that was about 30% with regular radiation and about 2 to 3% for the kids who had protons. Also, we know that radiation can increase your risk of developing a cancer. And so Mass General actually looked at this in the kids and tried to model what the risk would be. So with regular radiation, kind of the simplistic conventional radiation that is still a little antiquated, that is only about 10%. They don't use a lot of angles, so there's not a lot of spread of collateral radiation. With IMRT, actually, it's even higher. Even though it's more sophisticated, what it's exposing them to is low-dose radiation to multiple areas. With protons, it's about 5%, which is almost about 4% is kind of the baseline average that most kids would even be called with. So protons really don't dramatically increase your risk of a second cancer. All right, this is also a very telling tale in this day and age of national health care and trying to be more health care cost conscious. This was a great study. This was out of Sweden, where they have nationalized health care, and they actually are obviously want to make sure that all their treatments are cost effective. And so they took their kids who went for proton therapy and then compared them to the kids who had regular radiation. And they actually found in the patients who survived their cancer, there was a 23,000 euro saving per year of the child's life because of the fact that patients were going to the doctor less frequently, had less diagnostic testing, had less medications. So all those things factor into, even though protons cost more up front to deliver, it actually costs less to maintain the child afterwards because they're living a lot more normal life than the ones who've had all the damage from the treatments. All right, prostate cancer. So we've known over the years that as we escalate radiation doses for prostate cancer, our chance of recurrence of the cancer or beating the cancer goes down. So recurrence goes down. Complications, however, will go up. So you can see, as with regular radiation, as the dose of the radiation goes up, the complications go higher. With protons, giving very similar doses to conventional radiation, the recurrence rate might be about the same, but the complication rates are much lower. Let's go to this study. So this is a comparison because a lot of people talk about how there's not much data out there. And I do have to say that there's not a lot of, or there's really no randomized data, meaning we don't have data where half the patients got protons, half of the patients are getting IMRT. Those studies are being done now, and we're participating in those. But if you put these studies side by side of some of the leading institutions for regular radiation versus the ones who do proton therapy, you can look at MD Anderson, Houston, Texas, one of the premier cancer centers. They also now have a proton facility, but at that time they did not. This is a study from the Netherlands. This is a study from Great Britain, and this is a study from France, all using X-rays to fairly high dose treatments. Their 5-year cancer control rate, so the PSA being lower and staying down, was roughly about 64 to 75%. With the toxicity, so gastrointestinal toxicity or GI toxicity, grade 2 toxicity means it's a mild form of side effect, so maybe some discomfort, something that could be handled just by rest or over-the-counter medications, don't really need a doctor for. That was roughly about anywhere from 20 to 33%. For grade 3 toxicities, this is where you're actually going to the doctors for this, need prescription medication, sometimes going to the hospital for. That's about 5 to 10%. So not too bad. So overall, probably about 30 to 40% gastrointestinal toxicity. But if you look at the Proton study, the Proton Radiation Oncology Group study, this was a study with a combination of Loma Linda and Harvard, so our first 2 proton centers in the country. They combined their forces and did this study and looked at protons for this type of situation. They had a 91% cancer control rate at 5 years. They had a 17% mild side effects rate and a 1% severe side effects rate. So even though we don't have any true head-to-head comparison, we have the side-by-side comparison that seems pretty compelling. All right. Also, 5-year data is okay. Obviously, for prostate cancer, you need longer follow-up. And so we have 10-year data from Memorial Sloan Kettering versus the Proton study. Memorial Sloan Kettering in Manhattan, one of the premier leaders with IMRT for prostate cancer, treating to very high doses, even a little higher dose than what the folks at Harvard and Loma Linda gave. They have an 81% cancer control rate or PSA lowering rate. The Proton group had about a 93% rate for the low-risk prostate cancer patients at 10 years. Okay, Looking at, when we look at the kids as far as risk of, overall risk of second cancers, they also did that for prostate cancer. Your baseline risk when you are diagnosed with prostate cancer of having a cancer unrelated to that sometime in the next 5 to 10 years is roughly about 4% if you don't get any radiation, so if you have surgery. With conventional radiation, it's about 10%. With IMRT, it can be 11 to 15%. And then with protons, it's about 6%, which is not dramatically higher than the baseline risk.
That is a comment. Back up a little bit, but too far.
Okay.
Your sidebar there, according to the study,
Mm-hmm.
what other type of cancer was developed using photon?
So typically photon-related cancers are sarcomas. Those are the typical ones that you run into because that's an induced one. Now, it typically takes 8 to 10 years for a sarcoma to form after radiation of any type. So it is not something that happens instantly. It is something more kind of down the road that we're always kind of on the lookout for.
Is that just happenstance or is it directly related?
It's hard to say sometimes because if it happens within the, obviously if it happens within the radiation field, there's a high chance it is.
Probably.
If it's somewhere else, then it's hard to know whether it truly can be contributed to that. So.
Not just necessarily seeded.
Right, correct. And usually they can determine what type of cancer it is and whether it's related to the initial cancer. Okay, so this is another study. Like I said, there's not a head-to-head comparison yet, but this is as close as they can get right now. So the folks at Harvard, they actually partnered together with a consortium that looked at prostate quality of life after radiation. The Proton Center at Harvard took 95 of their patients treated between 2004 and 2008. They then went out and sought all these 153 IMRT patients and matched them, kind of PSA for PSA, Gleason score for Gleason score, to make sure their parameters pretty much matched, to basically do a fair comparison. So they had similar PSAs, similar Gleason score. None of them had hormone therapy. Sometimes that can kind of jade the result. So bottom line is they looked at the quality of life that these patients reported after the treatments. And what they found is that gastrointestinal toxicity, genital urinary toxicity were all worse in the patients who had IMRT. Sexual function was about the same, had similar decline or maintenance. And this basically just said that definitely protons are not worse. It could be a little bit better, and then hopefully the randomized trial will help answer that. Okay, so for lung cancer, this is some of the compelling data that we have out there. MD Anderson kind of pioneered the work on lung cancer with protons. And so what they did is they actually did a comparison of the patients that they treated with 3D conformal radiation, IMRT, and protons to see where they were as far as the side effects profile. And you can actually see, if you want to look here, they were only able to get to 63 gray. That's just a quantity of radiation as far as dose to those tumors, just because any higher would have really caused a lot of radiation exposure to those tissues. Protons, they were able to get to 74 gray with the patients that they treated. They had a side effects profile, esophagitis, the grade 3 side effects, so the severe esophagitis where it required feeding tubes, liquid feedings, IV feedings. That was about 18 or 20% for the 3D conformal and almost to 50% for IMRT. It was only 5% for protons. Pneumonitis, where they cause significant scarring and irritation in the lung so that people get short of breath, severe intractable cough. That was about 30% for the 3D conformal. IMRT was better, but protons was better still. All right. Now, dose for dose, maybe the patients weren't, as far as cure, not doing as well because the dose wasn't as high. They actually compared this with the RTOG study, which actually ramped the patients up to 74 gray, which is similar to their treatment. Looking at their survival rate at 1 year, it was about 73% versus 86%. 1 year progression-free survival, meaning no evidence of cancer, it was about 50-50 for the patients who had regular radiation. It was about 63% that they didn't have cancer in that situation. And then you can see here the esophagitis and pneumonitis rate was significantly improved with that. Okay, so we're wrapping it up now. So take-home points. All cancers like I said at the beginning, should be approached in a multidisciplinary fashion. So it shouldn't just be a radiation oncologist that sees a patient. It should be a medical oncologist. It should be a surgical oncologist to make sure all the avenues of treatment need to be looked at. Patient care in our facility is very much a team approach. You have the concierge or the front desk staff, nurses, therapists, the physicists and dosimetrists to help us plan the treatments, and the physicians. And this is something where the team, nobody's above the team. The team has to function together and in order for us to properly treat our patients. We have a state-of-the-art facility at Central DuPage Hospital. Not only do we have protons, but we also have high-dose rate brachytherapy, stereotactic radiation. We're also getting a gamma knife very soon. We have IMRT, image-guided radiation, obviously with the proton beam as well. We're very committed to, and as you heard, that I'm the lead investigator for our clinical trials, because I think that until we prove to the world that protons is effective, we're not going to have the availability of this to everybody. Because of insurance type of hindrances and things like that, we'd really have to prove this. So we are part of the Proton Collaborative Group. It includes our facility and also Oklahoma City, New Jersey, and Seattle, University of Pennsylvania, the Indiana University facility. When Michigan comes online, you have WashU in St. Louis. The Walter Reed Army Medical Center, actually, they don't have a proton facility, but all the veterans are tied into the University of Pennsylvania. University of Pennsylvania had a lot of VA administration type of support in order to build that facility, so a lot of our veterans are able to get their treatment through the University of Pennsylvania. We have some international sites that are participating as well. So we have the Paul Scher Institute in Sweden, and then the medical center in Groningen is being built as we speak. We have trials for our prostate cancer patients. So, we know that if we have less collateral radiation exposure, we usually treat most of our prostate cancers over 8 to 9 weeks, because we want to give that treatment slow so that the normal tissues kind of recover in between each treatment. But if there's less collateral radiation exposure to these other tissues, perhaps we can go faster. So what we've designed is a treatment for our prostate cancer patients who are low risk, meaning the kind of the lowest and earliest stage of treatment. We treat them with a regimen that can be done in 5 treatments as opposed to the 8 to 9 weeks. For our patients who kind of have middle of the road cancers, we've been able to speed it up and utilize a 28 treatment regimen on this study as well. All right, other things that we're looking at, not only prostate cancer, we're looking at pediatrics, breast cancer, lung cancer, and some of our kind of accelerated treatments for head, neck, and breast cancer. We have an accelerated treatment for our lung cancer that's looking at. This is a collaboration between us and the University of Florida. And we also have a collaboration with the proton facilities at MD Anderson and at Harvard, where we're doing a pediatric registry study, a prostate lung cancer study, where we are comparing IMRT and protons. I think that's going to be 2 very exciting studies that hopefully will really prove this modality. We're doing a lot of gastrointestinal cancers, head and neck cancers, and brain tumors as well. Finally, like I said, I have significant interest in basically propagating this treatment for our kids. We're participating in the Children's Oncology Group trials. Not only are we looking at the brain tumors, but some of the solid tumors in the body. So Hodgkin's lymphoma is one thing that we're looking at, neuroblastomas, of which I'm one of the primary investigators on. And then we also have the Pediatric Brain Tumor Consortium trials, which are spearheaded by St. Jude's. All right, so bottom line, we know that in order for us to really make this available to everybody is we have to make it more mainstream. And the only way we're going to make it more mainstream is to prove that these results are going to show basically equivalence as far as cure. And hopefully we'll be able to show improvement in those respects. But the main thing initially is that we are going to get better toxicity profiles or less side effects with this treatment. All right. Finally, all the standard radiation treatments are still being utilized and still should be utilized. So regular radiation, brachytherapy, image guidance is important so that we know that we're on target, accurate, and precise with our treatments. Protons hopefully will improve the side effects, and research will really be the only way we're going to validate this. So we're just seeing the tip of the iceberg with much of what we're doing right now. This is what we're treating, and I think we can expand on this dramatically. And so research and data will validate this, and it'll ensure our future, and this is our future. So we want to have this available for our kids so it's more commonplace than what we have to battle nowadays with insurances and things like that. Thank you for your time.
Yeah. Is this an acceptable procedure with insurance companies, or is this one of those big question marks we'll wait and see?
Yeah. So what we've worked out a lot of contracts with.
Oh,
Could you repeat the question when you answer?
I'm sorry.
Before you answer?
Okay. So his question was, has this been an accepted treatment modality with the insurances, right? Okay. So the insurances right now, there are a lot of things that are covered and that we've worked with insurances to get covered ahead of time. And there are things that we're definitely battling with, and meaning that the patients who come in, who we feel this is a very valid way of treatment, we will submit their claim and kind of fight through the appeals. So it's individualized as far as what we think we can win with. There are, let's just talk about breast cancer, for example. Breast cancer is something that's very new as far as utilizing that with proton therapy. Most insurances will deny us. What our policy has been, and at this point it's an unwritten policy, so maybe we should shut off the cameras. But what we tell patients is that we will battle the insurances for them, and that denial will not be a barrier for us to treat them. We're going to go ahead and treat them regardless of whether the insurance covers or not, and we'll work out the details in the end. Because if we never prove the modality, then we'll never win this battle for the future. And so, but some insurances are coming around. So, I have to hand it to some of the insurances where they basically said, if you enroll them on a clinical trial, we're willing to support that. And so that's Medicare's, for prostate cancer, that's Medicare's stand, is that if you enroll a prostate cancer on a clinical trial, they will cover proton therapy for that individual. So it's very, it also varies from state to state. There are certain things that are covered in Texas that aren't covered here. So we have to kind of go to them, find out what they did to get arguments to fight the insurances up here.
What about brain?
What's that?
What about brain?
Brain, for the most part, we haven't had a problem with, except for the high-grade glioma cancers. Most insurances will say nothing makes a difference. Is what they're saying is, no treatment is going to help anybody's survival.
It does or doesn't? Is that what you're telling me?
Well, we think that it can, and if we help in the survival, then we want to be able to help that person survive with the least amount of side effects. So it's a case-by-case basis as far as how we're going to fight those battles. But for right now, brain is an area that, as long as it's not a high-grade glioma, it typically will be covered.
How do you train the doctors for those insurance agencies that their opinions may be just a little too tight and not open enough to try something?
Sure. So we actually have a lot of conversations with medical directors of insurance companies, and we have to bring out a lot of studies that we do, and also studies that have already been done, which is nice. There's a lot more data coming out because there's a lot more centers. The other thing that that helps now is, because we can do both regular radiation and the proton treatments, we will actually run both plans and show them side by side, saying, hey, look, if this was your brain or if this was your body, would you want this dose going to there, or would you want it like this?
You don't say that it's your brain or your body, it's your child.
Yeah, it's true.
Your loved one.
Yes. So I think that it's starting to become more compelling. We get a lot of initial denials, and that's routine anyways for most insurances. So we're trying to win those battles. And the thing is, these are the same battles we had with every new innovation. And so we just have to get through these hurdles. Sure.
Most of your patients, how do they arrive at these different locations for the proton therapy? Are they recommended by another doctor, or only because of word of mouth, or?
Yeah, it's actually more internet searches and word of mouth than it is referring physicians, because even the physicians are not as educated. So we're actually trying, speaking at this type of forum, I am glad to do them because I don't think enough people know about it. And if I tell you and you tell other people, it actually helps. And we actually go to doctors' offices and try to do the same thing.
So people like us will talk to their doctors about this and see what knowledge that they have.
Sure.
And if they have none, which I doubt, really, I'm sure they hear what's going on, but, if
And we
it's
have,
more
like-
beneficial,
Yeah, and that's what we're trying to get out there. And so, with the packets that we have here, we actually have physician packets as well that we'll send to physicians. A lot of times when a patient comes to us self-referred, we'll actually send to their primary doctor or whatever the physician packet so they can kind of have an idea of what we're doing. And when we finish a treatment like this, we also send out, when we complete our treatments, kind of the pictures of how we designed the radiation as well. Our patients, as you go through the treatments, you will have a sit-down session with one of our dosimetrists, and they'll actually go through how the radiation was delivered and how that's designed. Yes?
How does the proton therapy compare to the IMRT in terms of cost?
Sure. It is about 30 to 40% higher.
That's why the insurance company doesn't like it.
Exactly. And so what we try to impress upon them is the fact that, just that one study showed a 23,000 euro saving per year. So somewhere down the line, this cost saving is going to happen. Now the problem with that is that that doesn't win over the insurance companies because you can change insurances. So they only care about what they're going to pay for right now because they may never gain the benefit of you getting this treatment down the road.
Especially if you're older.
True. Yeah.
but if you have Medicare,
Mhm.
if you have secondary insurance, what experience have you had with?
That's actually not a bad thing. Actually, most secondary insurances will follow Medicare.
Right.
And so if Medicare agrees, then they will agree. And we've actually had not a bad time with Medicare. So,
you just pick up the phone and
yeah, and that secondary usually follows suit, so it's usually not bad.
So you've had this from 1990, and there's maybe 10 facilities in the entire country?
Yeah, now there's about 14, yeah. So
14.
it's that's why.
2014, there's 14 facilities.
Yeah, that's why that
That's unreal.
a lot of physicians are even balking at it because they can't get it. And if they can't get it, they're not going to recommend it. Now, this is something that is kind of starting, I can talk about it now. Northwestern is merging with Central DuPage Hospital. So Northwestern's Cancer Center and Radiation Center is now much more promoting of this modality, whereas before they were kind of downplaying it. But they're now participating. Loyola, physicians who we've always been friendly with, they are now participating as well. So they're going to start treating their patients at the Proton Center, Northwestern and Loyola, which is great because that does mean that they're going to start spreading the word out. They're going to start having access to their patients with it. So it is a good thing.
And Lutheran?
Lutheran is, Lutheran, with the fact that we are still the same group of radiation doctors, send their patients directly. It's not a partnership, but because I was at Lutheran, and I was the medical director there for about 8 years before I went to the Proton Center. And so because of that, my group is still there. And so they're still my colleagues, and if they feel it's a proton case, they'll consult with me, and then we'll bring them over if need be.
But you're not.
I'm not at Lutheran, but we're still part of the same group. And I do cover, physician-wise, I cover that facility when people are on vacation, things like that. So I'm still part of that. North Shore is not affiliated with us, but yeah, that's true. You never know how, everything's becoming one big conglomerate.
My North Shore doctor did mention that would be a possibility.
Proton therapy, yeah. I think more people, as the word gets out, the understanding helps with taking away some of the fear, because a lot of people felt it was still experimental, and they didn't even know that it had been around since the 1990s and there was data. And so bottom line is, now that everybody's getting more educated, they are going to be a little bit more open to looking at that possibility. Okay.
And are they still doing the regular photon?
Oh yes, yes, and there are definitely situations, and people always ask me, well, if you have this, why would you ever do regular radiation? There are still situations where regular radiation is fine. So if you had a case where you had a tumor in the arm or in the leg, where it's really not close to a lot of critical structures, you could do protons. Protons can be done with anything that the regular radiation can be done. But the regular radiation, even if it penetrates through, it's not going to cause any collateral damage to anything that would cause you any long-term effect. So at that point, going to get protons, which does take a little longer than standard radiation. So it is a longer treatment time on the table. It can be anywhere from a third longer to 50% longer time on the table, which sometimes is very uncomfortable for patients. That can be something that is a little bit worse with protons. And the machinery obviously will get better and get faster, but that is something that's different.
So the newer machines are maybe a little better than the ones that came out first?
Yes, yeah, because the ones that kind of were designed at Harvard and at Loma Linda, a lot of those were kind of their own engineers on site developing them. The ones that are kind of available now are the ones that are kind of mass produced and are kind of run by the engineers. So the ones that we have are kind of the latest and greatest models. They came from Belgium, and they are able to have a high kind of quality control rates, and we actually have engineers from that company on site 24/7 that they work on the machine.
2010.
Yep.
And the Anderson's is 2006.
Right.
Is yours better?
No. I mean, if you're talking about 2006 versus 2010, that's not better. They're going to keep upgrading their machinery to do that. But when you talk about like Loma Linda, I was actually at Loma Linda before we opened our facility to kind of see how they did their type of treatments. And their machinery really needs to be upgraded. So they've upgraded, I think, 1 out of their 5 machines. So it is something that probably slowly they're going to have to upgrade each room to.
There'll always be an evolving technology.
Sure.
It's
Yeah.
just,
With anything like this.
it gets better with more experience.
Right. And they're building them smaller. It's just like your phone. Like your cell phone used to be like this suitcase, right? So now, so everything gets faster and smaller, and so I'm sure they'll do the same. The machine at St. Louis is a 1-room unit. We have 4 rooms in our facility. It's a 1-room unit so that it's cheaper to build, and if you have 1-room units, then you can have more of them throughout a larger area. So.
In all these centers that you talked about, is there 1 or 2 that stands out as the Porsche of
Actually, right now, of the facilities that are available, 14 of them, about 60% have the IBA machinery, which is what we have. So that's kind of the standard that's out there. There are a couple that have the Japanese models. I told you there was one that was the Russian, and then there are a couple that are from Germany. So there's obviously, as more and more centers come up, the different types are going to be available out there. Yeah. So.
How about the experience of the technicians? Some have been doing it for a longer time.
Sure, right. And so our facility was unique in the fact that when we started it, we had a training facility built that was kind of a simulator. So, you have pilots who have flight simulators and things like that. Well, we actually had a proton therapy simulator in Bloomington, Indiana. So everybody who actually treated and started patients at our facility had to spend about 3 months there before starting treatments with us. So they actually basically treated and set up everything like a real machine would before they ever got on the machine. Now, there were some who joined us from the other proton facilities and joined us, but there were others who were standard radiation technicians who came and then got the training to do it. And so they all had to be certified before they started on the machines.
And it sounds like your training has to be as much engineering as medicine.
Yes, and so we have a staff that has 10 engineers who they rotate, and like I said, 24/7 they're on site. And we have now I think 8 physicists, and we have about 8 dosimetrists. So we run the clock pretty much all day. Our facility operates from 6:30 in the morning till 10 at night. So that's a lot longer than a standard business day.
It's your local CERN in business.
So yeah, the machine runs basically 24/7 because between 6:30 and 10 is when we have the machine to treat people. And then after 10 o'clock, they run kind of quality assurance tests. They run trials of the patients who are going to get started. They're running those type of treatments on there to kind of make sure what we planned on the computer works out on the machine. And then they do preventative maintenance overnight too. So there's somebody at the center always working.
And what is the cost of one of these?
Well, that's part of why a lot of people don't have them. So this facility cost $150 million to build. And so nowadays, that's roughly the cost of building one of these centers. I think Mayo Clinic's center costs $250 million to build, but I think they have a couple more rooms and a bigger facility. Wash U, their one-room facility, I think costs about anywhere from 30 to 40 million, I think. So,
You have to have a couple of lottery tickets.
yeah.
Thank you so much for your time. And
My pleasure.
sharing